respects to elders past and present. Okay, so Telecare is the largest virtual specialist healthcare provider in Australia. We integrate with about 13 public hospitals, receive referrals from about 4,000 GPs, and we have right now over 300 specialists on our platform, which deliver virtual healthcare to Australians all around the country. Generally in regional and underserved areas, we run virtual outpatient clinics. In Queensland, we run virtual inpatient clinics. We're in some detention centres. So really, any organisation which has a large consolidation of chronic and complex disease patients, we can integrate our software and our services and quickly get those patients seen efficiently and effectively. But today, I'm here to talk about RxPad. So the story behind RxPad is that by delivering these services, being the virtual hospital itself, we are also the software provider and a software developer. Usually software providers don't run virtual hospitals and virtual hospitals don't develop software. I think this is what's been our moat and really what's been our major advantage. We have really deep insight in terms of what the specialists need, what the hospitals need, what the patients need. So given that we're with the AIDH today, you all know the problem, right? Like digital health is growing. Last year, 1 in 4 patients experienced a digital healthcare consult. However, the systems which are in place right now are not really built for digital health. You've got PMSs, legacy systems, which assume physical interactions. You assume that you have the doctor in a room, you have the admin staff outside, people can walk down the room and they can talk. So e-scripting was a huge problem for us all, the first couple of years of our journey. We had virtual specialist consultations, 8 out of 10 consults resulted in a script. So what was happening? Scripts were being sent out by fax, via email, via paper mail, and you had these a lot of issues. Scripts were lost. We had issues with what was called double dipping, which was patients photocopying their scripts and trying to get double scripts. You had doctor shopping where people get multiple scripts. You had scripts which didn't have certain management tools in place, such as real-time prescription management. So things like this, which made scripting first of all relatively unsafe, but also not streamlined. Not to mention you looked at faxing the script out by mail. It's 3 or 4 minutes for the doctor to write a script, and maybe 5 or 10 minutes for the admin staff to put it in an envelope, $1 a stamp, all that stuff, which came with the issue of physically having to deliver a script for a patient. So it was a no-brainer for us to develop our own cloud-native, mobile-native e-scripting solution. But when we developed this, we had one thing in mind. We knew that e-scripting it was already a thing. So our innovation wasn't e-scripting itself. It was the idea of how do we democratize e-scripting for large-scale clinics, for hospitals, for a lot of clinicians which already used existing PMS and EMR solutions. And we did that by looking at modularizing the e-scripting solution and really just focusing on that and building multi-directional APIs and being able to quite quickly and rapidly and safely roll out, integrate with large-scale EMRs, PMS systems, or existing virtual operations. So you can think of RxPad, and why it's called RxPad is that it's really a script pad, but it's mobile native and cloud native, and it integrates quite quickly. But along the way, we also introduced some features. So we integrated with MIMS, which allows you to quickly select the medication, get guidance. What else we did was we integrated with My Health Record, ADHA to initiate the IHI validation lookup. So we knew that patient was, real, and then they were who they said are. We obviously have clinician validation on there. So all the things which I mentioned earlier, which made paper scripts unsafe, we looked at building features to actually mitigate those uncertainties and be able to very quickly deliver the script virtually to a patient. So for the doctors, what they get is that they get a really easy to use e-scripting platform, which is fully integrated. If they're using another platform, and I'll give some examples later, they just click on a button and they can then send the script using the MIMS database. They can do things like also S8 medication, authority scripts is all built into the system, and ultimately saves them less time and makes it safer. For the patients, what they get is they get the e-script, which probably you guys have all experienced, that little QR code on your phone. It can be sent directly to the pharmacist or sent to the patient's phone, email, or SMS. Because it's a digital script, if the doctor messed up somehow, they can quickly cancel the script, they can edit the script, they can save favorite scripts for the patient who needs ongoing script. It's really anything that is about script management and script optimization we've built into the platform. And last year, we rolled out our first major integration with Health Direct Australia at a federal level with the 1-800 SIC hotline. So it's the 24-hour GP on-call service. And the key takeaway from this was that we were still a relatively small, early stage SaaS product, so we spent a lot of time co-designing the process with them and learning about what their physicians needed and what we need to do to optimize. So we went through a co-design period of about 6 months where we sat down with their admin staff, we sat down with their doctors, and traced out their clinical workflows to make sure that at a particular stage, at when the doctor needed to send a script, they could simply click a button and get that script done. And that's been a huge success. And then the results are, we sent out a whole bunch of scripts, but mainly you can see that 58% of patients are in regional areas, which is really what we've experienced delivering virtual health as well, where it's in the regional areas where people get the most benefit. There are not as many doctors. They'll need more virtual health. And having an e-script, and the key takeaway here with this integration was that the most successful thing is, and you don't really think about this, is that it's the doctor to be able to send a script out and the patient to receive it instantly and simply hold up their mobile phone to the camera and go, "Thanks doc, I received my script." So that alone saves so much administration, and you can't imagine how many times the patient's like, "Oh, I don't have my script, doctor, can you send me a new script?" So that's like a call to the admin. Then the admin has to escalate to the doctor. The doctor then has to find the patient, rewrite it, give that physical script back to the admin, and for the admin to then put in another envelope, which takes 2 or 3 days to send it. But this solution ultimately mitigates all that. And then now we have also what's admin control. So if the patient loses the script, the nurse can just log on and go, "Oh, you've lost your script, that's okay. I'm just going to issue another SMS straight away," and the patient gets it. Instantly. So our next integration is with, I'm sure you've all heard of ConsultMed. ConsultMed is probably Australia's largest leading provider in e-referrals. And this is part of our design process and our virtual kind of concept as well, where, what comes after a referral? Obviously the consult, and then during the consult, what happens? Someone needs to generate a script. So again, we took that idea of the clinical workflow and what's most suited for a clinician, where they review the referral, it comes in, they look at it, they have the consult, and straight away, afterwards when they need to send a letter back to the GP or write a clinical report, they can simply click a button and we take the data via API straight from ConsultMed and then generate that script using that data. So there is no data replication, you don't need to put in the patient name again, you don't need to put in their Medicare card number. We do the IHI validation and then we validate it back into the platform. So everybody's happy, the patient gets their script, and then I guess one of the key learnings between these two integrations, so you can see the Health Direct platform being a service-based integration where we ultimately integrated directly with their workflow, and the ConsultMed is a SaaS to SaaS integration where it's two software platforms enhancing capability. I guess the key success, and I think why the uptake has been so rapid, is that we've put the integration at the point in which the clinician has needed to use that particular tool. So we haven't just slapped a thing on it and straight from panel number one. So as soon as you log in, it's like send a script. We've done it in a way where we've mapped out these clinicians and their workflows, and at what stage in terms of ConsultMed, they've required the need to actually send a script. So usually at the end of a consult, so the end of a referral read or the end of a GP letter, and then we provide that kind of button to them. So naturally it flows onto them, and it feels quite natural for them to do, and then it saves them a lot of time as well. And for Health Direct as well is, it's the same thing. During the consult, they're able to, at the end of the consult, and that workflow guides them naturally, step one, do the virtual consult, step two, put in your notes, and then you get a prompt saying, well, would you like to now send a script? Naturally, we've designed it in a way which is very, I guess in the industry, you feel like it's good user experience, and we've been able to do that because obviously we run our virtual specialist services as well. So again, what have we learned? I guess apart from what I've just experienced, like no one can build a platform which does everything. We deliver virtual healthcare across 30 subspecialties, 300 specialists, public hospitals. You're going to need solutions and you're going to need people who build things really well. ConsultMed does e-referrals really well. We do e-scripts well. But you need to think about interoperability, you need to think about integration moving forward. So obviously, things like building scalable data structures, CSIRO with FHIR, HL7, you need to look at data structures moving forward, infrastructure which allows you to scale and a common language. You also need to consider what kind of specialty, subspecialty, primary healthcare, secondary healthcare, and the workflows. You need to put that tool in front of the clinician for when they need it, so you will get better uptake, better user experience, and then when they get used to your tool, they will sing praises around it. We recently rolled out integration with eHealth New South Wales as well, single sign-on, and we did that because a doctor probably doesn't want to sign up to multiple platforms, and eHealth has all their credentials. So from eHealth, they click a button and they're registered and ready to send e-scripts straight away, because otherwise they would have to go through a separate sign-on. So all those user experiences, all those things, anywhere you can eke out efficiencies and time and give it back to the clinicians. Initial specialist consult is usually 45 minutes, a follow-up is around 15. So for every 15 minutes you save, that's an extra consult you've generated for the patients who need it. And if anyone's trying to have a specialist consult recently, it could take sometimes years to book in a specialist at a public hospital. Conclusion, okay, so here we go. So I think moving forward in this industry and for software platforms like ours or ConsultMed, which are usually called utilities or microservices, where they focus on doing one thing really well and a particular tool, it's all about looking at interoperability, integration, and then it's all about co-designing your software and your tools with the clinicians and the user in mind, and looking at their workflows and when they're actually going to really need your tool to increase hopefully their efficiency and effectiveness of how they deliver their consults. And probably the last finding is that we need to also now build software tools to enable more virtual care, because although at the end of the day one's a face-to-face consult, one's a virtual consult, in terms of the complexity and the workflows and the administrative pathways, sometimes it's day and night. Okay, that's me. Thank you very much.